to the Seattle Grand Challenges Summit. I'm Matt O'Donnell. I'm Dean of the College of Engineering here at the University of Washington. I got involved in this personally, though, about a year ago when I went to a first meeting of this type that was sponsored by Duke, which was just to talk about the Grand Challenges and their impact on life, and of course especially impact on our students, because for many of these will be what defines your careers over the next 30 years or so. And as often happens, if you get excited about something, you usually get volunteered. So we were volunteered to do this, but again, we're very, very excited to have it here and kick off 2 days of events. We have over 500 registrants for tomorrow's events, but today's a special day to kick it off because it's really focusing on the students. And I can think of no better way to do that, to kick it off, than to introduce our opening speaker, which is Hugh Chang. He's the Director of Special Initiatives in the Office of the President at PATH. And he's going to tell us a bit about PATH, but PATH is a very special organization that is in Seattle and is really meant as a bridge between the developed and the developing worlds in the area of health. Off their website, they define themselves as an international nonprofit organization that creates sustainable, culturally relevant solutions, enabling communities worldwide to break long-standing cycles of poor health. By collaborating with diverse public and private sector partners, PATH helps provide appropriate health technologies and vital strategies that change the world. We are honored to count Hugh among UW alum. He received his graduate degrees in bioengineering here. So please join me in welcoming Hugh Chang.
Thanks. Thanks, Dean O'Donnell. I really appreciate the opportunity to come and talk to you about what we're doing at PATH, and also to talk to you about sort of some of the engineering opportunities that I think exist in global health. What I'll do this morning is talk to you a little bit about PATH, as Dean O'Donnell had mentioned. But one of the things that I'll focus on is to try and identify some of the creative engineering opportunities that I think exist in global health. Creativity, I think, is one of the keys to being a good engineer, because often you have a lot of different tools available to you, but it's how you actually use those tools to create solutions. And believe me, in the global health space, we need a lot of new solutions. In global health also, one of the things that you'll see from my talk is that there's a lot that has to do not only with engineering the specific technologies, but also engineering relationships, engineering partnerships, and working with communities that you want to benefit by your efforts. So what I hope we do as a result of this morning's talk is not only identify what some of the sort of very specific engineering challenges might be, but also to help open your minds to how you might need to think about working as you develop your careers going forward. To help frame what PATH does, I thought I'd start with a few maps. And I think these are interesting both because they're illustrative of a couple of different concepts, and they also highlight some of the basic inequities that we're trying to address at PATH. So here, what you see is a very familiar projection of the world where each of the countries is represented by the proportion of their land mass. So, you'll see what looks like a very familiar map. But there's this site, worldmapper.org, that actually does these country projections based on different statistics. And so this next one on population basically shows the size of the countries in proportion to their population in the world. And so you see now India and China really expand. In fact, Japan is much larger than its sort of land area projection. So this is an example of how you can take these statistics and then wrap them around a projection of the world just to highlight some different things. The next one that I kind of like is around fast food. This is actually a projection in 2004 of the over 30,000 McDonald's restaurants that existed in the world at that point in time. And you'll see that there's a disproportionate number of them in the US, but you'll see Japan has a huge number of them as well. And there were a few. What's interesting about this is that tiny sliver down in Africa that expands just a little bit is South Africa. There were a few, in 2004, there were a few McDonald's restaurants in South Africa. But this sort of is a fun representation of what you can do with some of these statistics. R&D is one that Path thinks about a lot. And this really represents one of the core issues that we think we want to address. And you'll see a couple of things. One is R&D is certainly concentrated in the industrial world, in the US, in Europe, in Japan. In 2002, which is the year in which these statistics represent, $289 billion was spent on research and development in the US. Now, it's true that some small portion of that research and development is dedicated towards trying to find solutions for people in those areas of the map that are not represented by R&D. But the vast majority of the R&D investment is made to be delivered in those areas where that money was spent. If we take a look at the next map, you'll see this is a map of the deaths from infectious and parasitic disease. This looks at all of the deaths in 2002, and you can see that they're concentrated in almost the opposite set of countries as the R&D investment was. You'll see Africa and Southeast Asia as huge areas where the burden of death from these diseases occurs. And one of the challenges with these diseases is that they're manageable. Many of them are curable. Many of them are preventable through vaccines. But there's a basic disconnect between the R&D investment that's made in the industrial world and this disease burden that exists in the developing world. And that's one of the things that Path tries to do, is we try to address that health inequity. We try to take some of that R&D investment, understand what technologies apply in the developing world, and create partnerships and innovations around those technologies so that we can help address these problems. So, Path's vision is a world where innovation ensures that health is within reach for everyone. And innovation is really the key term in there. We look for appropriate technologies. Path actually is an acronym that stands for the Program for Appropriate Technologies in Health. And throughout our 30-year history, we have looked for the technologies that are developed but have the right characteristics to be useful in the developing world. And I'll go through a couple examples of these so that you can sort of understand better what we mean by appropriate technologies. But innovation is sort of the key word for Path. We approach our mission by looking at three different things, and it's been our experience over the 30 years that we've existed that you have to look at both advancing technologies, which is certainly core to our innovation mission, but also strengthening systems and encouraging healthy behaviors. What we mean by these three things is you can build a great device, you can build a great mousetrap, but if you don't have the systems that are going to use that mousetrap, and in the case of global health, use these global health interventions that are designed for the appropriate level of training that healthcare workers have in the health systems, that are designed and provide education to both the healthcare workers as well as the patients that should benefit from these, and the governments who are going to be paying for these interventions, that if you can't encourage those healthy behaviors, you won't get uptake of that innovation. So you can create the greatest product in the world, but if the health systems in the developing world and the beneficiaries of those products don't understand why they're important, they won't actually create any impact. So these three components, advancing technologies, encouraging healthy behaviors, and strengthening systems, all go hand in hand in ultimately creating the health impact that we target by our innovative projects. Just a little bit more background on Path. We are a global organization. We have about 900 staff worldwide. Over half of that staff is in our field offices, which are located in Africa, Southeast Asia, and Latin America. We have a significant number of staff located in the US and in Europe, and typically that staff is working with the research and development partners that we have that are that span both the global north, the industrial world, as well as the global south, the developing world. So I'm going to steal a little line from our CEO, Chris Elias. Somebody recently asked him, what is he looking forward to in this next year? And his answer, which might be a little strange for somebody from Seattle, is he's looking forward to rain. But let me explain why he's looking forward to rain. He's talking about rain in a city and a country called Ouagadougou. The city is called Ouagadougou. The country is Burkina Faso. Burkina Faso is one of the poorest nations in the world. It's located in West Africa. It's a landlocked nation. And Burkina Faso is one of 22 countries in the meningitis belt in Africa. In fact, it's one of 7 countries in which meningitis is hyperendemic. When the rains come every summer, they actually stop the meningitis epidemic. We don't really know why. We don't understand what it is about the rain that actually reduces and stops the meningitis epidemic. But when they come, the meningitis stops. And the reason that Chris is looking forward, and we all at PATH are looking forward to that rain, is because of something that we've helped to create with the benefit and support of our colleagues at the Bill and Melinda Gates Foundation called the Meningitis Vaccine Project. Before I get into more description about the Meningitis Vaccine Project, I just wanted to point out some of the characteristics of epidemic meningitis in Africa. That little red circle is actually where the country Burkina Faso is in Africa. And as you can see, the cases of meningitis are very seasonal. They're very sporadic. And meningitis itself is a terrible disease. It has a very high attack rate. About 10% of the people who come down with meningitis die. And they typically die within the first 24 to 48 hours of symptoms. So it's a very fast-striking disease. Of those people who survive, 10 to 20% have severe side effects, severe permanent disabilities that range from mental retardation to deafness to other neurological defects. So it is a huge problem, especially in that meningitis belt in Africa. And when these epidemics occur, they overwhelm the local health systems. This is actually a picture of a hospital with patient overflow during one of those epidemics of meningitis. And you can see, conditions aren't great, and it's very difficult for countries to control that epidemic. In 2001, then, we worked with the Bill and Melinda Gates Foundation and the World Health Organization, and we created a 10-year partnership to create the Meningitis Vaccine Project with the goal of eliminating epidemic meningitis as a public health problem in sub-Saharan Africa. What the specific goal is to create a new type of vaccine for the meningitis strains that occur in Africa. And this actually, the strain that occurs in Africa is called meningitis A. And what we knew is that you could create one of these conjugate vaccines and that it would address the problem. Because historically, in the 1990s, there was an outbreak of meningitis in the United Kingdom. In the 1990s, during those outbreaks, there were about 1,000 people who died in the United Kingdom as a result of that outbreak of meningitis. That was the bacterial strain Group C meningitis. By 2001, 3 vaccine manufacturers had produced a conjugate vaccine against meningitis C. And in the subsequent years, there has been a significant reduction in meningitis in Europe, in Northern Europe, as a result of using this vaccine. What's amazing is that while 1,000 people died in the UK in the 1990s, and that motivated 3 vaccine companies to create this conjugate vaccine for meningitis C, that during that same period, during the 1990s, 100,000 people died in Africa, and no company stepped up to create a vaccine for meningitis A, which was the strain that was killing these people in Africa. It's a basic reflection of that inequity that I talked about earlier with the land maps, that the R&D that was present in the industrial world saw an economic opportunity for creating a meningitis C vaccine that addressed 1/10 the number of deaths that occurred in Africa. And what we are doing with the Gates Foundation and with the World Health Organization is we're trying to engage companies so that they can receive an economic benefit. Granted, it is a moderate benefit to the company, but it is a significant benefit to public health. So I'll talk a little bit about our model for how we actually address that inequity. An important thing for us in creating the meningitis vaccine project was actually to engage African public health officials. As I had mentioned before, that system strengthening and the encouraging healthy behaviors requires that you listen to the beneficiaries of your work. And so we worked with a number of different governments to identify not only what the specific strain was based on their epidemiological studies, but also what the primary barrier to uptake of a new vaccine would be. And the key thing that we identified was that the target price of this vaccine needed to be 50 cents a dose. At 50 cents a dose, without Path and our partners engaged in the development of a new vaccine, there's no commercial vaccine manufacturer who would take on this project. So what we did was we actually formed a significant sort of trio of partnerships. One is one of the biggest contributions that Path made is the administration of philanthropic funds on behalf of the Gates Foundation, where we provided funding to undertake some key activities. One was to engage a commercial partner in Europe to create one component of the vaccine. We essentially paid for this work to be done. The second thing was we actually worked with the U.S. government, and in fact, the FDA has a lab that had developed a technology, a conjugation method, in order to create the vaccine against meningitis A. And so Path, together with the Cinco biopartners in Amsterdam, worked then with a third partner. And that third partner is a developing world vaccine manufacturer called the Serum Institute of India. As their name implies, they're based in India. They actually happen to be one of the world's largest producers of vaccines. But they were very motivated to work with Path for a couple of reasons. One is their vaccine technology was relatively outdated. They needed access and they needed to understand how to create these conjugate vaccines. The second is we had the relationships with the WHO and with other organizations in order to help, including the African ministers of health, in order to help identify what the right characteristics for the product would be so that that product got used and subsequently there would be reasonable amounts of sales in the developing world. Through this set of partnerships, we were actually able to create a meningitis vaccine for actually, I think it's 40 cents a dose. And who would have thought 10 years ago that you would bring a biotech company from Europe with U.S. government labs and a vaccine developer in India in order to solve these problems? It's an example of what I mentioned earlier, that in order to advance a technology, you not only need the core technical skills, but you need to be able to forge these strong relationships with partners like Serum Institute of India, with government officials like those in the meningitis belt, and be able to identify what the right characteristics are and what the right constraints are that you need to design your solution towards. So the result of this has been the creation of Menafrivac. It is a conjugate meningitis A vaccine. And what you see is actually a 10-dose vial for that vaccine. What I'm happy to tell you is that after, I guess we started this in 2001, it's 2010, after 9 years, what we've been able to do is actually have this vaccine go through phase 3 clinical trials in Africa, go through the Indian regulatory system. So we're using the drug controller of India in order to provide the regulatory approvals for this product. And last December, we received licensure in India to be able to provide this product to countries in Africa. Now, let me be clear. Path is not the one who's providing the product. It is our partner, the Serum Institute of India, who has undertaken investments in manufacturing, in training new personnel. We have helped to offset some of those costs, but they've invested tens of millions of dollars in their facilities in order to do this. And they've done that because they recognize two things. One is that there is a huge public health need, and there's a significant benefit that we will receive, and that SII will sort of gain in terms of goodwill in the global health community by undertaking this project. But the Serum Institute of India is a private, for-profit company. And the other thing that they recognize is they will be able to create a profit based on these product streams. So not only have we been able to sort of engage a set of partners to address a specific global health problem, but in doing that, we've also been able to show that there are real market opportunities and that we can create markets for companies so that they can now direct some of their R&D work towards these problems. Our goal then is to start introducing this vaccine later this year. And in fact, in 2010, we will be introducing this into Burkina Faso, into Mali, and into Niger. By 2011, we will go into Chad and parts of Ethiopia. The rollout will continue through 2012 and through 2013, so that actually by the time we get to 2013, we will have introduced this vaccine into all of the hyperendemic countries of meningitis in the African meningitis belt. So, why are we looking forward to rain in Ouagadougou? Well, certainly because it will actually bring an end to this year's outbreak of epidemic meningitis. But we're also looking forward to it because we hope that this will be the last time that we have to look forward to rain in Burkina Faso, and that by this time next year, it won't matter if it rains, that we will have delivered the vaccine and that we will have protected the population so that there is no more outbreak of epidemic meningitis. Thank you. It is certainly one of the exciting projects that we have ongoing at Path. We have many of these same types of products. We're working on Malaria Vaccine, which is in phase 3 trials in Africa. We're working on new ways to deliver medicines to help address postpartum hemorrhage, which is one of the largest causes of maternal death in the developing world. We're working on new vaccines for diarrheal diseases. And in all of those cases, we take an approach that I want to sort of describe to you now in a little bit more of an abstract way. And it's a model that we call product development partnerships. In product development partnerships, our goal really is to engage the private sector in creating some of these solutions. And the question that we ask ourselves is, well, all right, how do we do that? Because what this graph sort of represents is, for most companies, they have what's called a risk-return threshold, and they will undertake projects that are below that, so in the shaded area, where they believe that the risk is worth the return that they would receive. In most cases, for the public health and the global health projects that we're talking about, most companies view those as outside of their risk-return threshold. So the question is, how do you actually get a company to expand that threshold and undertake some of these projects? Well, we do it really in two ways. One is we help to mitigate risks. As I mentioned, we have a strong set of relationships with organizations like the World Health Organization, with individual countries' ministers of health, with other policymakers in the US and in Europe that can help create policies and help companies understand, by virtue of our closeness to the situation, what some of the design constraints are that they need to work towards. We can help mitigate that risk and basically make it a less risky project for them by our contributions. The other very significant way is to share costs. So one of the very explicit things we do, Path in 2010 has about a $250 million operating budget. Over half of that money we actually administer on behalf of our donors and provide to private companies. So a good example is these phase 3 trials that we're going through for the Malaria Vaccine Initiative. The malaria vaccine that is entering those phase 3 trials is is a vaccine called RTSS, and it was developed by GlaxoSmithKline, one of the largest pharmaceutical companies in the world. GSK has actually been working on this vaccine since the late 1980s, and they actually shelved it for about a 10-year period because as they got into the economic analysis, they realized there's no way they could make any money selling a malaria vaccine because the countries in which malaria is the biggest problem can't afford to buy them. So they made the right business decision for them, which was to not produce the vaccine. The Malaria Vaccine Initiative actually provided significant funding. We are contributing tens of millions of dollars, for instance, both to the development costs as well as to the costs of the clinical trials in order to advance that vaccine. And by absorbing those costs, we actually make it easier. We reduce the amount of investment that the private companies have to recoup as a result of their efforts, and make it actually a market in which they can make a reasonable profit. And recently, Andrew Whitty, the CEO of GlaxoSmithKline, announced that they will make, if RTSS is proven effective in these phase 3 trials, that they will provide RTSS at a cost of 5%, at a price of 5% over their costs. So they're significantly limiting their margins. They're basically recouping their costs in order to provide this, which will be a huge benefit to all of the nations that suffer from malaria. And so by mitigating costs and sharing risks, we actually use our product development partnership model to shift that risk-return threshold. Now, in return, one of the things that we need to do is negotiate terms to ensure that we capture that public benefit. So the area between the dotted line and the solid arrow really represents an investment that the public sector has made in order to encourage a company to undertake that project. And what we do is then we negotiate in order to receive that philanthropic funding, which is free money to companies. In order to receive that, they have to agree to things like preferential pricing for the public health sector. They have to agree to certain supply commitments and also to certain intellectual property commitments. And it is sort of the quid pro quo for our contributions of philanthropic dollars, free dollars to them, in order for them to undertake these projects. As I had mentioned, the thing that makes this work is complementary assets. And so Path really brings an expertise in developing country health systems. We understand what will work on the ground in places like Africa or Southeast Asia. We understand how to navigate this sometimes bizarre web of global health where there are different different entities that are paying for some of these health products. Groups like the Global Alliance for Vaccines and Immunizations or countries themselves. And those people who are paying for them are very different than the people who are actually administering and delivering them, the healthcare workers in the clinics and in the hospitals in the developing world. And those people are very different than the ones who ultimately need to choose which products to use, which may be the ministers of health and the other government officials. Those three entities really can create some conflicting motivations. And so one of the things that we do is we navigate that web and we try and help create alignment so that our private sector partners have a greater opportunity to actually deliver their products, reach that health impact, and develop a market. On the other hand, our partners have things that Path does not. We don't ever undertake the manufacturing and distribution of any of our health products. We will license intellectual property. We participate in the development process, but we don't have the investment to create a factory to create vaccines. We don't have the distribution systems in order to move vaccines from one country to another. And so we rely on our private partners to do that. In order for them to do that, they have to actually see an economic opportunity. And so between those two sets of assets, our assets and their assets, we carve an area of mutual benefit that enables both the public health impact that we hope for, as well as the economic incentives that they're working towards. So just after a little bit of describing some of the background of PATH and the Meningitis Vaccine project as an example of that, I wanted to go into two more specific examples. They are involved in the diagnostics for HIV/AIDS and in a whole set of things around vaccines. This is a pretty interesting picture. It's a graph of the leading causes of death in the U.S. for people aged 25 to 44. And clearly, the line that jumps out is that red line. That red line actually are the deaths associated with HIV/AIDS. And you can see right around the 1996, 95 to 97 timeframe, there is a dramatic decrease in the deaths caused by HIV/AIDS. And the reason that decrease exists is the introduction of a new therapy, the protease inhibitors. In fact, what this graph shows is how the uptake of protease inhibitors exactly corresponded with the decrease in deaths related to HIV and AIDS. And it is what I call one of the silver bullet slides. This really shows an amazing thing, that a single class of interventions, protease inhibitors, could decrease significantly the deaths related to HIV/AIDS. And this is a huge success. This is the United States. In order to achieve that success, there are three key diagnostics that were developed in order to enable protease inhibitors to adequately address the threat that HIV/AIDS posed. And those were the first test of checking for whether a patient has HIV or not. So you look for antibodies that the body actually generates in response to an HIV infection and determine whether a patient has HIV. If they do, then the patients actually go through a routine monitoring. So about every 3 to 4 months, patients go in and are measured for a specific T cell type called the Cd4 count. The Cd4 count is, or the Cd4 cells are the ones that are ultimately attacked by the HIV virus. And in fact, as the virus progresses in a patient, their Cd4 counts drop. When their Cd4 counts drop below 350 cells per microliter, then that is when they start this antiretroviral therapy, which includes the protease inhibitors. Now, one of the things that you may all be familiar with is that HIV is a highly mutagenic virus, and that's one of the challenges in creating a vaccine towards it. It is constantly changing. And one of the effects of that mutagenicity is that not all protease inhibitors work. So the second thing, once it's been determined that you need to start antiretroviral therapy, the thing you need to start checking then is to see whether the actual amount of HIV virus in your body is going down or not. And that's what's checked with this viral load test. And if your viral load starts falling, that means that the protease inhibitors and the ART therapy that you're receiving is working. If they don't, then there are other lines of therapy other protease inhibitors, other ARTs that they might prescribe in order to see whether the particular virus that's infecting you will respond to those treatments. But 3 key tests are required. 1, to determine whether you have HIV. 2, to determine what your Cd4 count is. And 3, determine what the viral load of HIV is in your body to see whether the ART therapies are actually being effective. This is a graph of ART therapies that are being administered and also the number of people who need them in the developing world. And that top line, which in 2008 ends at 9.6 million people, shows you that there are 9.6 million people who are in need of ART therapy. Their CD4 counts are low enough that they should actually start to receive that therapy. In 2008, only 4 million of those 9 million people are actually receiving the therapy. And, it's an amazing thing, actually. If you look at the progress, between 2003 and 2008, we've gone up by an order of magnitude in terms of the number of people who are receiving that ART therapy. But we still have twice as far to go. And one of the key challenges in effectively administering the ART therapy are those diagnostics, and in particular, the Cd4 and the viral load diagnostics. Because it's the Cd4 diagnostic that helps you know when to start the therapy, and it's the viral load diagnostic that helps tell you whether that therapy is being effective or not. PATH has actually been active in all three areas, and I'll tell you a little bit about some of the work that's going on, not only at PATH, but at other organizations to try and address this. Before I do that, one of the things that I want to talk to you about, though, is some of the conditions in the developing world. You saw from some of those pictures in the Meningitis Vaccine project that, what we're used to in terms of medical diagnostic laboratories and hospital facilities is very different than what exists in the developing world. And the extremes are sort of highlighted in this graphic. At the regional level, which is typically in urban centers in cities, you actually can find some hospitals that are equipped similarly to some of the hospitals that we have here in the US. But that level of technology and infrastructure and training drops off dramatically as you go down into the health systems. And as you reach the district, the clinic, and the community levels, the infrastructure decreases exponentially, the number of healthcare workers decreases exponentially, and the training that they receive decreases exponentially. This is an example of a picture of a diagnostics lab at a clinic level facility. And you can see, while they have electrical equipment, you never know whether the electricity is actually going to be reliable or not. Not only do you not know whether it's going to be on or off, but the fluctuations in line voltage are significant. And so most of our equipment in the US is assumed to use regulated sources of electricity, but that doesn't exist in the developing world. Clean water, something as basic as clean water, can't be assured. So there are a huge number of challenges in terms of the constraints, the operating constraints in low resource settings. The perfect assay for a low resource setting is cheap, it's easy to use, and it is foolproof. And while we'd like to have all of these characteristics, for some of the things that we're talking about for HIV/AIDS, that's challenging to meet. This is an example of one of those first diagnostics to be able to detect for the HIV antibodies. It's a product called the Hiv Dipstick Path. Actually worked on these in the 1990s and developed one of the lowest cost dipsticks available. Its initial use was actually in screening for blood banks, but its basic characteristics are used in very simple point-of-care assays that are used throughout the developing world today. So this is actually one example where we are pretty close to matching those ideal assay characteristics. It's very stable. It can sit on a shelf for months in the developing world heat. It works very easily. There's just a simple color change for technicians to monitor. It is very cheap, and it works well. In fact, one of the things that PATH was able to do was to use that HIV dipstick test, where we have a test both for HIV-1 and HIV-2, two different signature antibodies. And we were actually able to show that sequential use of those tests, which is sort of represented in that lower left-hand corner, can actually yield results that are as accurate as a Western blot test, for instance. So it's an example of using what we call appropriate technology and creatively combining that technology so that we can achieve some of the results that are similar to some of the more industrialized high infrastructure tests. Cd4 and viral load diagnostics are another story, though. Today, the vast majority of Cd4 counts in the US are accomplished by using flow cytometers. What you see here is actually a relatively portable flow cytometer. It's from a company called Guava. It's relatively low cost. It is used for doing CD4 counts. But it still costs something, I think, on the order of $25,000 to $30,000. It requires electricity, it requires clean water, it requires reagents. It is way too expensive. Plus, it would be used in more of a district-level setting rather than a clinic or in the community where most of these patients live. And the transportation difficulties for those patients can't be underestimated. It can take 2 days for a patient to get from their village to a district-level clinic. And so finding diagnostics that actually work at the community level or at the clinic level are incredibly important. This is just one example of a company called Zyomix that is actually creating a new type of CD4 test. And there's an initiative called the Cd4 Initiative, which is sponsored by the Bill and Melinda Gates Foundation, that is trying to find new alternatives to CD4 testing that can work in the developing world. And in this one, it actually is a pinprick of blood. You actually, I can't, if I could, well, one, I don't actually know how it works, but they told me if they told me, they'd have to kill me. So, because they're still currently in development, they're entering clinical trials. It does look very promising, but it basically gives a visual inspection 20 minutes after administration of the test to understand what a patient's CD4 cell count is. No electricity required. All of the reagents are in the kit. It's very stable. It is approaching those ideal assay characteristics, but it is using things that we would not think about in the industrial world because it has a different constraint space. Similarly, for viral load monitoring, one of the things that you have to be able to do is to collect a patient's RNA effectively and actually prepare that specimen. So one of the things that Path is working on are RNA capture devices and the ability to effectively and very efficiently capture the RNA, help prepare the specimens, and these ultimately get shipped to a centralized location for testing. It is an example of how we are trying to address sort of the low infrastructure requirements and break the problem space up into different steps. In this case, it's sample collection and specimen preparation in order to enable greater testing for viral load in the developing world. So, if there are two things that I could encourage you, if you're interested, to think about, it is how to create better CD4 tests and better viral load tests. And by better, what I mean are things that don't require electricity, that don't require instrumentation, that can sit on a shelf for 6 months in 40 degrees centigrade heat, and that can be operated and understood by minimally trained healthcare workers in the developing world. If we can do that, we can achieve some of that decrease in HIV deaths that were realized in the U.S. in the developing world. The other thing I want to talk to you about is vaccines and vaccine delivery, and in specific, the cold chain. So I don't know how many of you are familiar with the vaccine process. What this represents is sort of the entire process from actually ordering vaccines to receiving them and delivering them to patients. But a large portion of this process is what we call the cold chain. Most vaccines have to be refrigerated from the time they leave the manufacturer until the time that they are administered into a patient. And any break in that cold chain renders that vaccine useless. It is an infrastructure that was put in place by the WHO and by a number of organizations in the 70s and in the 80s and still exists today. But that system is actually increasingly coming under significant burdens. One of the burdens that it's sort of being subject to is that we are developing new vaccines. There are a lot of new vaccines that are in development. The HPV vaccine, which is currently available in the U.S., is targeted for delivery into the developing world. JE is a disease called Japanese encephalitis, which is an incurable disease, but it is preventable by use of a vaccine. Both of those actually are available today and are starting to be delivered into the developing world. cholera, dengue, malaria, all of these vaccines are in development. And so one of the challenges is we've had this cold chain infrastructure that's been put in place since the late 70s, the early 80s, and we are introducing new vaccines into that system that hadn't been anticipated when it was first designed. One of the clear issues related to that, then, is the volumes that these new vaccines require. Traditional vaccines like hepatitis B and some of the polio vaccines, for instance, only required about 43 cubic centimeters per child. But if we look at some of these new vaccines, pneumococcal vaccine, which is designed to help prevent upper respiratory diseases, that requires almost 4 times the amount of volume as the traditional vaccines. And the rotavirus vaccine, which is for diarrheal diseases, requires twice as much as the pneumo vaccines. So this cold chain, which has sort of a fixed capacity, is being burdened by these new vaccines, which hold enormous potential for the developing world, but require more space. This is just, I think, a great example of a refrigerator in that cold chain. And on the left-hand side, you can see that is 4,100 doses of polio and measles vaccines, and the entire inventory for that $4,100 for that 4,100 doses is worth $635. On the other side, you see only 625 doses of the rotavirus vaccine. The value of that inventory is almost $5,000. The differences in what this cold chain needs to be able to accommodate are significant. And subsequently, we need to figure out new technologies and new ways to help maximize what the cold chain can accommodate, as well as figure out how we can actually potentially get around the cold chain and pull things out. This is just another example. These are cold storage facilities in the developing world, and you can see the vaccine shipments are just piling up. They're running out of space, and if we don't solve this problem in the next 10 years, we may have all of the great technologies that we wanted, but that system strengthening component, that second part of our mission, is going to be critical to actually taking these new technologies and enabling them to have that, the health impact that we wanted. So, some of the things that PATH is working on and others are working on are different delivery different vaccine delivery modes, whether those are through nasal vaccines, whether those are inhaled, they can be through microneedles. All of these different vaccine delivery modes actually have the potential to enable vaccines to be developed differently, potentially in a dry format so that they don't have to be refrigerated. They have the potential to reduce the number of doses or reduce the amount of vaccine that needs to be administered in order to generate the immune system response. And they're going to be critical to, as I said, getting around this issue in the cold chain that we know is going to be just increase in the next 10 to 15 years. So the risk to not addressing these things is if we don't do it, we'll have these great new vaccines, but they'll only be sitting in the manufacturers' refrigerators. And the manufacturers will stop making them because they actually can't get them out to the people who need them. So figuring out how we actually get around the cold chain or improve the cold chain are going to be critical components to global health. And there are really 3 areas that we think about. One is cold chain technologies. So looking at things like solar energy to enable new refrigeration type units, or new materials that through phase change properties can enable the cooling of these vaccines without any power. Information technologies are going to be critical. One of the things that we need to know is, as a vaccine goes through its shipment, does it get subject to either freezing or heat? Because both ends of the spectrum damage the vaccines. And we're looking at mobile technologies that are coupled with cheap temperature sensors so that on a shipment-by-shipment basis, we can be alerted to issues in the cold chain and be able to make sure that anything that's in there is actually being delivered with the quality that we need in order to enable that global health impact. And then, as I mentioned, vaccines and delivery devices. One of the challenges in that is, in order to, for instance, create a vaccine that you intend to be delivered by some submucosal delivery mechanism, you actually have to start working with the vaccine producer when they start designing the vaccines. And so we are working with universities and companies at the early stage of their vaccine development to try and understand how we can actually get some of these new technologies incorporated and reduce the pressure on the cold chain. So, engineering, creativity, and global health. I think you have a great opportunity in front of you. There's certainly a huge universe of global health needs. They span everything from issues around child and maternal health to, in fact, one of the growing areas, in fact, I think this, just recently, in the past 2 years, death caused by chronic disease has surpassed the number of deaths due to parasitic and infectious diseases. So diabetes, cardiovascular disease, all of those conditions are huge in the developing world, but they can't use the same kinds of devices that we have in the US. A blood sugar test that requires a patient to buy the strips that are disposable won't work in the developing world. They don't have enough money to be able to buy those strips. You have to redesign the tests for some of those conditions. But what's unique in global health are the resource constraints and understanding what kinds of environmental constraints, both in terms of operating conditions, in terms of healthcare workers' skill levels, are going to be necessary in order for you to design what are going to be the appropriate and creative solutions to global health. So I would encourage you, as you finish your studies and as you think about what you want to do next, think about global health. There are a lot of issues that we can use all of your brain power to help us solve. And I think one of the things that it does is it taxes the creativity that you may have in different ways than some of the problems that are sort of maybe more familiar in the industrial world. So I guess my last message is it can be done. We've done it at Path, working with our partners. These are 3 examples. I told you about the Meningitis example on the bottom, but the top 2 are 2 other examples. One is something we call the Uniject. That was actually intellectual property developed by Path. It is a single-dose, single-use syringe that can be used by low-skilled health workers. And in fact, it is that packaging that we're looking at using, combined with a drug called oxytocin, to address postpartum hemorrhage in the developing world. And it can be then delivered, because of the simplicity of the packaging, because there is no requirement for the healthcare worker to pull a dose from a multi-dose vial, that this can be used by relatively unskilled midwives as they help as birth attendants in the developing world. And the other picture that I show you with the vaccine vials is one of something that we call our vaccine vial monitors. It is a temperature-sensitive label that is used to basically track how much heat that vaccine vial has experienced from the time it left the manufacturer until the time that it's administered into a patient. And in that case, that was a technology that Path helped develop with a small company in New Jersey. There have been over 5 billion of those vaccine vial monitors that have been shipped by that company. And it's another example of using creativity, solving a global health program, and using the economic incentives of the market to enable a company to participate and sustainably deliver those interventions. So I just want to thank you and thank Dean O'Donnell for this opportunity to talk to you. I hope I've shared some interesting information with you, and I think, do we have time for a couple of questions? If you have any questions, I'll be around. Otherwise, I guess I'll hand it back to Dean O'Donnell.
Thanks a lot. And we're not scripted for questions for this, but I'm going to ask one anyway, because I can do that. But what was interesting about the management of the cold chain, because I mean that is something which is, I think, engineering can play a big role in right away. But the 2 paths, one is about preserving the cold but having different technologies to do that versus changing the basic vaccine technology so you don't need it. Which do you think is going to have the biggest impact in, say, the short term, next 5 years?
Well, in the short term, I think it's going to be maintaining the cold and trying to figure out how we do that, because the design timelines for actually introducing new administration pathways is much longer than the design timeline for creating some of these phase change materials, for instance, to enable passive cooling.
Right. Great. Okay.